So, hi guys, welcome. Today we'll be looking at diseases of the pituitary gland and the adrenals. So, pituitary gland disorders can either be pituitary hyperfunction or hypofunction. So, these are reflected in disorders of the adrenals, the thyroid, and the ovarian function. So, under thyroid diseases, let's look at goiter. So, goiter is basically enlargement of the thyroid gland and is classified in different ways. We have simple goiter, which can be diffuse or nodular. So usually it is caused by lack of iodine or defects in synthesis of thyroxine hormone. For the toxic goiter, may be diffuse or also nodular. So produces excess thyroxine, that is T3 and T4, and manifests with signs and symptoms of thyrotoxicosis. So neoplastic goiters can be benign or malignant, and thyroiditis such as Hashimoto's disease also have infected related goiters. So these are rare goiters and may be caused by tuberculosis and syphilis also. So what are the clinical features? So most patients are asymptomatic, and pressure symptoms consist of engorged neck, veins, dysphagia, stridor, hoarseness. So, in hyperthyroid patients, signs and symptoms include weight loss, diarrhea, heat intolerance, sweating, tachycardia, heart failure, tremors, so eyelid lag. We also have exophthalmos and menstrual disorders. So when a patient presents with this, we have to do certain investigations that include an X-ray, that is the thoracic inlet. We also have to do thyroid function test, that is levels of T3, T4, and TSH in thyrotoxicosis. So we also find needle aspiration for cytology purposes, so to rule if the goiter is benign or malignant. We also have to do an ultrasound for the thyroid to see how anatomically it appears. So, how do we manage this condition? So, for goiters, first of all, reassurance to a patient is very important because smooth non toxic colloid goiters, that is thyroxine, give 50 to 150 micrograms OD for 6 months. If it doesn't change, you stop the drug completely and you do follow up to see how far the extent has gone. For toxic goiters, usually it is managed conservatively, and we give anti-thyroid drugs such as carbimazole and methimazole. We also have propranolol and diazepam. For thyrotoxicosis, the aim is to treat and restore the euthyroid state. So you use the pulse rate and the thyroid function test if available, and you also monitor the progress of how the patient is faring on. So antithyroid drugs such as carbimazole we give 15 to 20 milligrams thrice a day for 3 to 4 weeks. So thereafter, it's reduced dosage maintenance for euthyroid state to range between 5 to 30 milligrams daily. So propranolol can be given 60 to 240 milligrams in basically three divided doses. So in places of carbimazole, there are other alternatives that can be used, such as propylochloric. It can be administered, but not exceeding 300 milligrams per day, and it's given in divided doses of 6 to 8 hours intervals. For methimazole, it may also be given instead of carbimazole, and the dosage is 20 to 30 milligrams once daily. The dosage may be increased to 30 to 40 days after 2 weeks, then tapered after euthyroid status has been relieved. So maintenance dose is usually 2.5 milligrams to 5 milligrams daily for at least 12 to 24 months before we can change into something else. Also, there's another option of radioactive iodine ablation, and this is indicated for patients in whom antithyroid drugs have failed to achieve the euthyroid state within 12 to 24 months. For instance, women, it's preferred in those who have completed childbirth. So in both sexes, it's preferably in those aged 35 years and above for this procedure to be done. So there is also indication for surgery if it's a toxic goiter. Also failure to control symptoms despite adequate treatment with drugs. So that's the only time we can be able to initiate surgical interventions. Thank you.